Today, we're going to talk about two strands of how we conceptualize health, descriptive and normative. We'll start by tracking down the descriptive side of how we think of health. This is the side associated with Boorse and Wakefield. To see health as descriptive means that when we say, this person is healthy and this person is ill, we're making claims about the way the world is. We're looking for something value-free, meaning that any rational person would look at the subject and, seeing the same data, would come to the same conclusion without any further implications than what they see. When Nasreen looks at this cat and says, there is a cat on the mat, she's simply observing the state of things, that this is a cat, and that the cat is indeed on the mat. Nasreen and her cat demonstrate what kind of data we would need to make descriptive claims, empirical data. So when we say health is a descriptive claim, we're saying that health can be measured, reinstated, and maintained by empirical data. To make a claim about health is to say, the empirical state of this biological entity is either healthy or diseased. So, health is predominantly biological in nature. It's also about function. Disease is when a particular body part, like a limb or a type of cell, an organ, or a system, fails to fulfill its function. Lungs bring in oxygen, the heart circulates blood to oxygenate it, T cells recognize antigens and induce apoptosis, and so forth. But how do we know empirically what something's function should be? Boorse answers that our definition of health must be statistical, because just knowing the state of a given entity in a vacuum doesn't necessarily tell us anything about the degree to which they deviate from the norm. So, his biostatistical theory of health understands disease as a deviation from the statistically normal biological function. We select a reference class of organisms with uniform function design, like an age group or sex, whatever makes sense for the kind of data we're looking at. We chart out the average function of those organisms, and disease is that state where the function is significantly diminished. From this position, we're going to be most interested in patient signs, that is, the expression of the disease state as the physician measures it. And again, those measurements will be fundamentally biological and statistical. We'll gather the signs into a set, and then compare that set to average functions and to the probabilistic set of diseases with which it most overlaps. This is, arguably, the dominant model for how we think of disease both professionally and in general. There are plenty of critiques. It makes some problematic assumptions about reference classes and the power of statistics, for example, and has tended to struggle to account for environmental factors, but it remains quite strong and viable. Where it's weakest, though, is from the other end, the normative strand. As Kahane and Savulescu argue, there's no intrinsic reason why a deviation from a statistical norm is bad or needs returning to the norm. Here, on the side associated with Hare and Engelhardt, we see health as making a normative claim. This means we see statements like, this person is healthy and this person is ill, as entailing some claims about the way the world should be. More straightforwardly, if health is normative, what we're really saying is that disease describes a state that we should not want to be in. If the state we're in is bad, then we should want to be out of that state. So, rather than biological deviation from norms, we really base our ideas of health and disease on whether people want to be in that state. Take, for example, having the generic set of illnesses that we call the flu. We feel achy, we have a fever, we feel nauseated. These are bad states to be in. By definition, if these states are bad, we want not to be in them. And so, we call those biological states we don't want to be in disease. From this perspective, we're likely to be more interested in the symptoms of disease, the patient's experience of that disease, in that they're telling us that those experiences are bad. This presents us with some interesting situations that illuminate questions about authority and justification. Baldness, for example, is largely considered a state we do not want to be in, a bad state. But there's nothing particularly biologically harmful about being bald. Conversely, polycystic ovary syndrome, or PCOS, can include hair growing on women's faces. This is a state many women want not to be in, a bad state and therefore disease, when there really is nothing biologically harmful about women having hair on their faces. So, Boorse can't be completely right that health and disease are measured entirely by biological measurements. Thinking about health as a normative claim helps us to see where some elements of disease might have a social etiology, so that in the case of, say, drapetomania, a, quote, disease that made enslaved black people want to run away from white people who claim to own them, we can challenge the normativity behind that disease label. It might be useful to pause here and point out that Boorse and Hare have somewhat different conceptual objectives. In philosophy, we talk about conceptual analysis, which looks at how concepts operate in different contexts. For example, what does health mean in the American for-profit hospital system? And conceptual engineering, which aims to change how we use those concepts and replace them with better definitions. It's a little unclear the degree to which Boorse or Hare see themselves as doing one or the other, but it seems safe to say that Hare is doing more conceptual analysis. Ironically, he's not saying health should be normative in the context of, say, drapetomania, just that it is normative, that it aims to make justified or ostensibly justified claims about how things should be, potentially regardless of what the science may or may not say. Just as ironically, Boorse, on the other hand, seems to be involved in at least a little bit of conceptual engineering, especially around psychology and mental health, by stating that disease should be biological and statistically measurable. The tricky part, and why all this really matters, is that regardless of whether health and disease are normative or descriptive, they have prescriptive implications. Engelhardt writes that the concept of disease acts not only to describe and explain, but also to enjoin to action. If someone has a disease, we are to various degrees, depending on our role, obligated to ameliorate that disease state. The complicated questions are, what parts of disease are we enjoined to treat, and who's enjoined to treat what? This is where we move from Hare and Boorse's definition of disease to Engelhardt's discussion of etiology. If you're not quite there yet in the semester, you can feel free to pause here. If you're reviewing, take a break, catch your breath, especially since you're probably playing this at 2x speed. If you're not in my class, welcome. Hope you're enjoying the video, but you should take a break too. Pet a cat or something. Okay, back to the questions. Imagine that you're a general practitioner. Your patient, we'll very hypothetically call him Peter, is presenting with a set of signs and symptoms: intense stomach pain, vomiting, diarrhea, fatigue, joint pain, and weight loss. Blood tests show that he's anemic, has low vitamin B and albumin, low hemoglobin, and elevated white blood cell count, CRP, and calprotectin. MRI and colonoscopy show irreparable damage in parts of the ileum. Clearly, Peter is not healthy in either a Hare or Boorse sense. These are a pretty dramatic deviation from normal species typical function, and it sounds like a very bad state to be in, hypothetically of course. We are, as Engelhardt says, enjoined to action. Let's treat him. But wait, what are we treating? Engelhardt gives us two ways to conceptualize this. The first, the ontological model, looks to cluster signs and symptoms into solidified categories that constitute a disease entity, a thing. In this case, Crohn's disease. Crohn's is an autoimmune disease that predominantly affects the digestive tract. It can be treated with steroids, immunosuppressive drugs, or biologics in severe cases. Perfect, the ontological model says. We know what the disease is, and we know how to treat it. The aim is diagnosis. Not so fast, the physiological model says. Diseases aren't things. We don't even know what causes Crohn's disease, and it appears differently in different patients. Not to mention that in Peter's case, there are a lot of things that need treating beyond just Crohn's disease in an ontological sense. There are issues for a gastroenterologist, a surgeon, probably even a psychologist here, depending on which cluster of variables and their relationships we choose to focus on. Let's get one thing very clear. This is not a binary choice. A good doctor is going to need to understand disease as ontological. You have Crohn's disease. We treat that with Entyvio. And also physiological. You have some malabsorption, so I'd like you to take these vitamins and adjust your diet in this way. But patient's health isn't a job for just one doctor. It needs a whole team of doctors, some of whom will be thinking more ontologically and others more physiologically. Let's look at how these two interact with descriptivist, Boorse, and normative, Hare understandings of disease. A descriptivist ontologist who uses the BST and thinks of diseases as ontological entities will measure the biological deviation from the norm and then cluster those deviations together to determine what the patient has. They'll then deploy the statistically suggested treatment for that disease's primary etiology. This probably sounds like the way that many doctors think. A descriptivist physiologist will begin in the same way, by measuring deviation from the norm. But they'll be more concerned with the way that the individual patient is injured by the malady and addressing the likely cause, per biostatistics, of those injuries so that they can address those deviations. This sounds, to me at least, a little more like the practice of a general practitioner. A normative physiologist will see the patient's signs and symptoms as claims about which states of their physiology are bad to be in. More particularly, More particularly, they will likely attend to disease processes more than a disease thing, and that they'll be interested in how these collections of bad states interact in the endeavor to bring the patient back to a desirable state. A normative ontologist is harder to imagine. This would be someone who sees the concept of disease as primarily linguistic and social, making claims about desirable and undesirable states to be in. But they would also see disease as describing discrete entities. This makes some sense if we're talking about widely agreed upon diseases. Tuberculosis exists, they say. From the bacterium to the signs and symptoms to the treatment, TB describes an entity. But they also say TB is a thing that's bad to have, which is a perfectly reasonable thing to say. Except that, for yet another completely hypothetical example, our patient Peter might have hypothetically picked up inactive TB while teaching a course on medical history in London. But it hasn't hypothetically actually impacted his life, and he was pretty asymptomatic. He did take a lot of drugs for a few months. And, more importantly, the normative ontologist is going to be very confused when it comes to less straightforward conditions like autism or depression or chronic pain disorders, because they'll believe both that some of these things are determined by social claims about what's good and bad, and also that they exist ontologically as things. Where we land, after all this conversation, is, in Engelhardt's words, that the concept of health helps define the concept of disease by providing the telos for the medical enterprise. That is, health is the end goal, the ultimate aim of medicine. As we've seen, health and disease may be questions of biology, and they may be questions of norms. They may be about things that exist, and they may be about clusters of physiological experiences. They may be questions for a general practitioner, or a surgeon, or a public health official, or a psychologist, depending on which elements one foregrounds. What matters for medical ethics are the implications of which stance we take. It's possible that to take a descriptive ontological stance on one disease is a perfectly just and effective way to address the disease, but that the same stance will cause great harm when applied to another. For example, as we're about to see in the rest of this course, the loose collection of diseases, conditions, states, and experiences that we often lump together under disability present particular challenges to all these models. And that will be the subject of many more videos to come as we think about what health might mean.